So, my dear friends, you can start the start part of it, then I'll go ahead with the talk part of it.
Yes, sir. Yes, sir. We will introduce you.
Yeah. So, actually, Dr. NEERAJ JAIN sir needs no introduction. Everybody from India and across the globe knows him, and he's the senior consultant working at the interventional spine and pain specialist at Shoda's Specialty Center. And he, at this age, I can say just 1 year before, he has also completed this CIPS degree, and he is one of the few members.
CIPS 17, 2017.
Yeah, 17.
Okay, if there's anything more, I'm ready for that also.
Yes. Multiple young pain physicians are just inspired by you, sir, and it's a great opportunity to listen to you once again, sir. So we are just going to start with the topic.
Yeah.
I hand over mic to Neeraj, sir.
Okay, my pleasure, my friends. I think we have a very important and relevant topic today, where I feel it is going to make a big difference what we are and what you can be after this very, very rewarding and very good procedure. And I must say, when you talk about vertebroplasty, I say nowhere in the pain management there is a procedure which is so rewarding and in a way for the patient, for yourself, for the specialty. And it's a very instant thing and almost 100% and complete permanent relief for the patient. Many, many patients. So I wish everybody to take this talk and carry your message, and I certainly try to put it in a way that many of you can start doing it, and we're already doing it like many people sitting in the panel. They can really upgrade and upskill on further difficult fractures, because I keep giving this talk, improvising vertebral augmentation for expanded indications and for difficult fractures many times. And I've been doing talk in the spine surgeons gathering and neurosurgeons gathering. I did one lately in Izmir neurosurgeons classes, webinar classes. It is very, very well taken. And believe me, many procedures we're going to show you today, the improvisations, are not yet been done or duplicated anywhere in the world, even by the surgeons or neurosurgeons. So this is about the vertebral augmentation, and I'll just a minute. Yeah, that's right. So I did another talk in the New York for last 2 years, and this year also I'm going in November. And the talk was advanced innovative pain interventions, make it the difficult spine cases possible. And you see one other slide which really shows that how do we do difficult vertebral body fractures. This was one of the topic there, and I gave a talk. Yes, there is no conflict of interest that except that I want to heal my patient's pain as much we can, and it is our imperative duty put together. And WHO already declared the pain as a fifth vital sign, and we know it well, and that really proves that how valuable is the pain relief for the patient point of view. And I tell you, pain is a pain is a pain, and I keep saying time and again, there is no symptom which is as ominous as pain. So that way, pain is the most painful symptom in the body, in other words. And these patients keep needing help here and there, and WHO and UN and other forums already describe chronic pain is as a disease. So it's not just one of the things, it's a syndrome, it's a disease by itself, and it has to be treated. And that's where just sympathy is not enough. Like many people just sympathize or empathize with the patient. No, you have to be proactive, do something about this patient, and you can relieve their pain. So that's what should be tried. Yes, there are so many medications available. We know about NSAIDs, and half our dialysis units are filled with analgesic nephropathies. Then GI bleeds are known, and all those blood transfusion, other things are there. Melena sets in after a few days of the analgesic.
Recording in progress.
And then thereafter, once you go ahead with the narcotics, and you know what it leads to. Ultracid is already getting bad name for that, and is getting a prescription drug, and very, very tight prescription drug. So we know about the narcotics and other things. But why, if there is a good treatment available, why should we go for the long-term medication? Very, very clear. An instant relief is always better. And here is a WHO pain ladder. We all know about the WHO pain pyramid, or pain ladder for that matter. And we start low and go high. And when an acute patient comes in a fracture, obviously you can't think of a ladder now. You have to go higher in the treatment. And here is the intervention. When you talk about higher interventions, the spinal cord stimulators, I must say they should have been vertebral augmentation right in that category. And people have been trying other modalities. And here is something, if it is an osteoporotic fracture, patient comes to me, I don't go for other things, all this track. Here is something, I have a straight, I put in needle, put in a cement, fill it and forget it. It's a quick fix phenomena. So I would rather like to go for that. And people know it. Spinal injections are overriding the surgery and other things already, an open surgery for that matter. not only for fractures, for many spine conditions, pathologies, disc pathologies, facet, SI, and other pathologies. And with the regenerative medicine coming up, is all the more getting improvised and used in the even in the joint and arthropathies and all, RMSK syndromes. So we should try to make use of these good modalities. Well, there are patients who are really in pain and they are asking for death, and they say what a pain, and suddenly you do a good job, and then patients say what is pain. So that is what you want, and then life becomes a gift for them. But this is all you have to do it. It doesn't happen by itself. No, understanding the osteoporosis, everybody knows it, but I'm keeping class from basic to the advanced most. So people can join for the basic, who want to know basic, and people who want to go ahead and learn more, they can join up to the advanced cases also. So this is a combined talk for both basic and advanced in vertebroplasty. And this is very, very simple. Empty bone syndrome, we know it happens in osteoporosis, very, very common, especially with the faulty lifestyle these days, people not taking sunshine, and with the deficiency of the calcium and D3, it is happening. It is day in, day out. And we are next to be blamed because we are using so many of steroids for our epidurals, root blocks, joint injections, and these all steroids can add to the osteoporosis which is pre-existing. So if I have a patient who is osteoporotic fracture, I will avoid all steroid injections, even if I need to give for other reasons, like a root block or something coincidental. Avoid it, go for something else, because it won't allow your bone to heal healthy. Well, another reason why we are having so many fractures is there is age expectancy is increasing with each year by year, and there are more and more people who are living 80, 90 and 100, and it says 80% of people over age 80, they have a radiological fracture. They may not be complaining, but they must be having radiological fracture. But if patient is complaining, obviously it is not to be missed, and it's a big volume. If you look at the epidemiology or the number, and it's a US number, and I can't say about India because we are not in a better health state. There are like 7 lakh vertebral body fractures each year, they've been saying, but it is going to be more for India. Obviously we have a bigger volume, and the older age people population coming up, and definitely faulty lifestyle and dietary issues. One important thing for my friends is the fragility fractures are mechanical consequence of a biological disease. This is to be understood. If you are doing a fracture cure by cementing, it does not mean the whole body is taken care of. So you have to treat the osteoporosis by all means. And we have so many drugs available these days. Anti-resorptive ones like denosumab, we have a teriparatide or other drugs which has come in. There are more and more add-on drugs now, bisphosphonates, calcium. You got to give it. And I tell my patients when I'm cementing one fracture, I say I'm giving you this, not for this fracture because I've healed this fracture of yours. I'm doing it that you don't have other fractures coming up, which is the case very often, and I'll explain you on that. This is how you give all your medications to do with the osteoporosis. 18 to 24 months, you can combine D3 and calcium, other things. Then we have a teriparatide, bisphosphonates, we know it, but denosumab is better than the oral bisphosphonates. Once in a 6 months injection, given up to 10 years, means 20 injections in total. Teriparatide, it said, is you can give up to 24 months in a lifetime. You can choose 6 months for 4 times or 12 months or 2 times like this. You have a choice. A patient has an osteoporosis, severe one up, you try to give it there and then. Then oral calcium and lifestyle, exercise. Sarcopenia is there, understand, not only osteoporosis. You have to correct the sarcopenia also. Now there are long-term consequences. It's like a wheel, death wheel for many patients. And osteoporosis sets in. There are so many comorbidities which comes in place, and patients are really having increased mortality. And they have done a study for age-related mortality, age matching, and they found the people with the osteoporotic symptomatic fractures are more likely to die early and more often than other comparative population. So it's very much studies are there. They are well conducted, and that's why it's very, very important to treat symptomatic fracture. Then they age match with other people. And these are the 3-column theory. People should know it, especially the residents. These are 3 columns, and we are talking about reinforcing the anterior column. That's the most important. This anterior column, that's more to be reinforced. Posterior column, if there are fractures, you avoid it. They are meant for surgical cure. And that is because anterior column takes 80% of the weight of the spine. So we have to reinforce it. When I find a collapsed fracture, I don't leave them open, especially in senile osteoporotic patients. Now these are the classifications. I pulled it up for you because normally I don't need it, but yes, for education point of view, type A compression fractures are the one we are interested, and they are the one which are commonest ones, which happens in osteoporotic setting. Other fractures, they are more of trauma, accident fractures. You are not inclined to look into those patients. Here is a set of patients. Normally said, if it is incomplete burst or burst, it is not to be done, but I'm doing it. I tell you some techniques how we can do it, and it's a good number of such patients which need it. Well, this is what it is. Understand the mechanism, the geography of it. The anterior height loss is there, one should know it, and these are the Cobb's angle. One should see how much is the Cobb angle, and this is the posterior vertebral angle is the another one which should really understand. If it's getting bigger, it should be 90. If it's getting bigger, 110 and all, you should know it. And this can be done in a comparative MRIs for patient. We left alone for conservative management. Don't leave them open. Have another look at fresh MRI, and I'll show you some images. And understanding fact is, if there is one fracture, chances of having the other levels getting fractured is very, very high, especially adjacent levels one. And that is why you see all those granny and all those grandpas and all, they used to have this humpback and all, and this to do with the osteoporotic collapse or weakening or wedging, and they become a leaning tower of Pisa, and obviously then the fracture sets in at one time. Vertebroplasty, one should know where is the maximum occurrence is there. Dorsal lumbar angulation is the one where there is a transition D12 L1 are the one which is getting the maximum number of fractures. Some people can have it at other places also, in the lower lumbar levels and even the upper dorsal levels, but the mechanism of injury is not just pure osteoporosis, a little more loading also, and that is where you get those fractures. And understanding there are some drawbacks of conservative management. Many people will say, why straight away cement? There are objections to that also in some patients or by some specialists. We say yes, because bed rest and pain control, you can use braces. There is decreased activity, decreased bone density, increased fracture risk. So we do a FREX score. We always do a BMD, bone scan FREX score, and find out how much is the fracture level and understand the chances of getting more fractures. And there is going to be increased kyphosis. These are the negatives of conservative management. There are other issues also. If somebody has got a one fracture, the risk of subsequent fracture increases like 5-fold after first fracture, 12-fold after 2 or more fractures, and 75-fold after 2 or more what people call body fractures with low body mass index, like your BMD is less than 3, minus 3 or so. So these are people more likely. So we always combine these pictures, patient's requirement, clinical judgment, and then go ahead. Well, there are some people who are habitual fractures. They keep getting more and more fractures. You look at this patient, she had 10 different fractures at different years, and she used to come to me, she's only 79, she used to come to me again and again after a year or two, and straight away come with the request, doctor, cement me. That's what. And that's what in USA also. Some old lady has got a fracture, they drive to the center, get a cementing done, and come back home. It's like going to beauty parlor for them. So this is one of those things which people keep getting understanding the facts of it. Another time she had a pain, and this time it was not the vertebral body fracture, she had a rib fracture. She requested for a vertebral fracture, and she had a rib fracture this time. So you treat it, and she got admitted for a vertebral body cementing, but anyway, rib fracture are treated differently obviously, and she was fine with the pain. Because you have other modalities in your hand, if it is the other pain also. Like sometimes we get a hip fracture, sometimes we get other issues, so we can manage that also. Well, there are factors which influence this cascade of new fractures coming up or subsequent fracture. It depends on the bone properties, it depends on the neurophysiological properties of the patient, and the spine properties are there, which is local spine properties and global spine properties. These all pooled together calculate the chances of getting more fractures or healing of the same fracture. These all are to be counted in one place. Like this lady, we are looking for a vertebral body fracture, she has a hip fracture also. So understand, if there is another fracture, that is also counted as one of the fracture, even if it is not a second spine fracture. Many times people say they have this chronic pain syndrome. I would say before it becomes chronic, we will get cemented in the sand, we let cement in the bone itself. So that's what vertebroplasty is all about. Now coming quickly to the practical part of the fracture spine is painful remedies. I say it is there for Greek and Egyptian times. People have been doing, look at those pictures. I am surprised, astonished, what a beautiful science is there, even if they didn't have X-ray and mindset that it is this, and they were treating it so well. We have all those dorsal lumbar braces, that's minimum should be done. I have seen many people doing a flaw that they're putting a lumbar belt for a D12 or D11 fracture. You're causing more harm to the patient by splitting lumbar vertebra, at the D12, D11 fracture. and because there is going to be more movement on the D11, D12 then. So that's a wrong thing to do. So I always tell people, please give it elaborate if you have to give it if it's a dorsal lumbar fracture. Act in time. Patients come to me 2007 with this fracture. I do these days also. That time I was not doing it. But this is too late for a fracture to do this. Yes, you can do it now. And this, I keep telling about multiple fractures. You see, one fracture didn't go for cementing. Had a second fracture. Now she's coming to me for cementing. So I went ahead and did both, by the way, both of these fractures. But that's the wrong thing. Patient didn't understand, because patient was in the influence of other orthopedic surgeons, and after second fracture they realized. And lately I had a patient who had a fracture at this level, and look at another fracture at this level. Look at the kyphotic angulation. What a bad kyphosis patient is already set in. Look at this kyphotic spine there. What a nuisance. Why you allow all this to happen when you have a simple, straightforward cementing and correcting the sagittal deformity? Why should we allow it? And that is how you just accomplish this. Patient are left to suffer. These are my own setting patients. They come to me, they had a fracture, they were doing conservative management with other people, and then they land with me later on, and I find it's gone from bad to worse. Now what you can do is they say, please cement us now. What a silly thing. You didn't come at right time. You're coming when it's gone very, very bad. Now you're asking for a bigger job, trouble job. X-ray alone is not enough. Many times people do a flaw. They have an X-ray, go for cementing. No. Always and never. Always get an MRI or CT or something in your hand and know where exactly is the fracture. Now X-ray wise, this was the fracture, but actual fracture is here. X-ray wise, this is all normal spine, but there is a fracture here. X-ray wise, this was the one which was must have been troubling, but the actual trouble was here. So you should have both the images with you, and sometimes you need more images. Always try for a recent imaging. This image was done. Patient came to me from another town for just for the treatment part. I said I have to do a fresh MRI, 20 days only, and look at this, what a collapse. 20 days time, burst, open. It happens during transition. Try it. Many people flaw this. Tell the people, if somebody has got a fracture falling from a tree or anything, roof, never ever pull them in a flex position like they bring them in lap. No, it should be a hardboard, straight, or stretcher kind of thing. Not in the bed sheet. They come to the village with the bed sheet folded like an animal, and then all these things they happen, and they have a cord injury. Many instances, and they have a paraplegia, permanent sometime. Well, STIR is a good image to see, and it differentiates from the old from the fresh MRI. Look at this image. It will tell you this is an old MRI or old fracture or fresh fracture. And you got to treat obviously the fresh fractures. There can be multiple fractures sometime. So STIR images are very helpful in such scenarios. Another image, patient came to me for this fracture, and patient was getting treatment for this os hematoma and didn't realize that he has got a fracture also. So that was the one which I have been bothering. The whole idea put in this slide is there can be polytrauma setting. So there could be os hematoma, there can be fracture, there can be other things also. One should look at the whole scenario, whole picture of it, and treat patient in a wholesome way. The 3D and CT are very helpful, especially 3D reformatting. I keep telling people, make use of these modalities. I go to the scan rooms, have a look at all the morphology, fracture morphology, where to go, what is my track, where if I am going, how much is the collapse, which pedicle I have to choose. These all things have, and then the pedicle direction, other things. So draw your lines, even if you have to draw on the screen. Draw your lines and know where you have to go, start and go. I'll tell you again, another slide coming up. Well, bone scans are helpful in patients to differentiate whether it's osteoporotic or POTS or metastatic fractures, and you have to treat accordingly. If patient comes to me and I find it to metastatic, I'll first send to oncology unit and then ask them to come get back to me after oncological consultation. People have been getting surgically fixed, and look what's it. Patient has been fixed. Look at this, fixed, and there's a broken at two places. So this patient already fixed. Now this is all gone back. So they have to be. So they make a patient an RN man, but with a bad back. It happens very often. It's not great an idea. Many patients who go to surgical arena, they would like to go for fixation, 5-level fixations. No, it doesn't make sense to me. Look, this very clean looking fracture. I'm talking 2006-07. Didn't go for cementing. I advised for cementing. They didn't go for cementing. This was basically orthopedic patients that time. And I said, orthopedic guy, let it be cemented. He said, I'll conservatively manage it. And you just give an epidural. There was a small disc here. You would give an epidural. I said, you're doing a wrong thing to the patient, but I have to tell the patient. I informed the patient, told him that you got a fracture. If it doesn't heal, I'll have to do something more about it. This is what happens in about 2 months, 12 days or something like that, 2 months time. It's all wedged now. Look at this comparison with this. And now it is D11 and a big surgeon, 3 surgeons, the best of the neurosurgeons of India, and this good surgeon and orthopedic surgeon. 3 people are on the operating side, and they're doing a thoracolumbar fixation with the opening of the diaphragm and whatnot, lung, and they did a good fixation. This time they requested me, doctor, we are trying to put in screws. Their screws are not fixing, screws are not taking up. Can you put in a cement now? Look, I would have put a cement in one level, this level. Now they're asking me to put a cement in these 2 levels. I did put cement at these 2 levels. That time I was doing anesthesia practice. So I put a gloves on and put a cement in these 2 levels. Can you imagine? So I feel so bad. The other part of the story is, which is more important for you and me, is that he was in hospital, he had a hemothorax. They tapped hemothorax, he developed adhesive pleuritis. They corrected that, he was hypoxic. They gave him oxygen, he was hypoproteinemia. And they corrected hypoproteinemia, and he was given bloods and discharged, maybe a week or 2 weeks, after the admission, and to be brought back dead after a week or 2 of the discharge. So that is the sad story. Many times I feel bad for such patients. So I say we should respond to patient changing needs and times. And Ravi, this slide is important here. It says, the responsibility point of view is, no single raindrop believes it is to be blamed for the flood. But we all together in the medical community are responsible for what is happening, good and bad, in the medical science. So what to do? In this era of MAS, percutaneous vertebroplasty should be the first line of management in vertebral body of osteoporotic compression, senile fractures. Straight. That's my philosophy, until unless otherwise. And it's a simple one-liner, again, explain everything about vertebroplasty. I can close the class after this line, but I'll go ahead for everybody's sake. PVP or percutaneous vertebroplasty is an interventional technique in which the surgical PMA cement is injected, or for that matter other cements are there now, phosphate and all, under LA via a large bore needle into a fractured vertebral body under imaging guidance, providing increased bone strength, stability, instant pain relief, decreased analgesic requirement, increased bone mobility for the patient with improved quality of life and early return to work. Beautiful. And that is what is our duty, and we should. The indications are basically mostly senile osteoporotic fractures, and getting more and more rampant because of the age, increasing expectancy. Metastatic fractures are there, and it's also increasing because more and more people realize that we can fix these fractures, painful fractures, especially metastatic ones. And then we have the aggressive hemangiomas which are there, and we can treat those hemangiomas. And actually, to be truthful, the first vertebroplasty was started with the cervical hemangioma, painful in some patient, long back to 1984 by Dermond and other people in France. And it was just that they wanted to, like we do a we have those AV malformations, or what do you call, we put in those embolization of those hemangiomas and all. And this is what they tried. Okay, let's embolize it. They put in a drop or 2 of cement, and patient was pain free. Look, the history started, and it has become a history now, and is more and more people are getting for osteoporotic fractures now. It's such a beautiful thing. This was one of the aggressive hemangioma I cemented long back. Well, there are patients who are steroid dependent. They are very heavy dose steroid for either for lung reason or for the reason of the steroid dependency, and they keep getting fractured. One of my patients has got another 7, 8, 9 level fractures cemented. If you very closely watch it, 1, 2, 3, 4, 5, and this is if it's 5, this 6, 7, 8, 9. That's how you just can intelligently count it. And yes, one has to do it if it is required. It's painful fractures, collapsing ones, and patient is totally steroid dependent. And it is also done for spine strengthening before the surgery, for cementing part. And obviously we know the spine is the commonest mat, and we keep getting these fractures, and we should try to treat them if possible. Well, there have been contraindications earlier which are shrinking day by day, and but still there will be few ones which we have to be very, very careful. If it's a posterior burst fracture with neurological symptom, or unstable vertebra, or with the pedicle fractures, or with the posterior through and through fracture, all three elements, and those are the ones which should be sent for surgery. Or there are other minor smaller things, allergy, coagulopathies and other things. Well, there have been initial complications, I'm telling you, but if you learn it, train yourself well, wonderful procedure. And but start right, actually start with easy fractures, and that will give you more confidence to go ahead and do more difficult ones, and that is how it is to be seen. Well, cement leakage is a menace. Wrongly done, overconfidence or complacency can cause it. So I always radiopaque my cement. I never want this to happen to my patient. This was by one of the surgeon who did this procedure, and look at the cement lying all the canal. Now they have to open this patient, and many times they have paraplegia, and sometimes they die also because if it goes to the lung for any reason. Another patient they cemented, and look at the whole thing is lying open, and patient is not able state, is in big pain, and this is it. Another patient which they cemented, and they had to do a fixation also. Like initially they did a fixation, and this was the one which got even worse after cementing. So they did another procedure on this later on, and they caused more trouble for the patient. Another such patient, a good fixation done, and cement leaked into the epidural space, and now they have to redo everything. So these are few things I have been called to put in a spinal cord simulator, because patient was able to walk still in spite of this pain, but with the pain. So, but it doesn't work, so you have to do a redo surgery. Very recently, I got a patient from one of the surgeon who did the cementing. Look, the cement is lying in the foramen here, or by the side of the root, and I had to go and do a root block for this patient. Patient is fine, and the intercostal root I can do a neuralize also. I can do RF, I can do phenol, and many times I do it. But there will be situations. This one of the study from outside. You can do a DRG stimulation if it is really getting irritated for some or the other reason. What is the best route of cementing? We start from the for the cervical we go anterolaterally, like we do discography. For lumbar we obviously go transpedicular, sometimes parapedicular, depending on whether we want to go across. And for dorsal you have to go parapedicular or costotransverse, obviously. These are tracks, one should know it. And there is an overlap also, depending on its upper lumbar or which kind of or lower dorsal. Those overlaps are there. Well, understanding, starting for upper outer quadrant of the pedicle is important. Look at the starting upper outer quadrant. These are the cadaver bone. I am just showing you starting from here and getting into this. Look at this upper outer quadrant. This one needle, this is the second needle, contralateral side. I obliquely showing you a zero of the needle for that matter. These are two needles I am talking about. When you're going from the upper outer quadrant, getting into the vertebral body, never ever breach the medial border of the pedicle. If you do that, obviously there's going to be cement leaking into the canal, and that is one has to be careful. This is the cut section of that. Going for upper outer quadrant, transpedicular without breaching medial border pedicle, going across all the way, turning anteriorly. If you're getting two needles, it's okay, you can be more straight. But if I do very often use single needle these days, I go more across, not breaching, saving this medial border and getting across, and one needle is good enough. Why I'm doing so? Many times when I used to do with two needles, when I started putting cement in the first needle, the cement started leaking out from the second needle. So what's the big deal? If they are same track, same cavity, why should I use this second needle for that matter? And so I stopped putting second needle in first time. I would do oblique first needle, cement it well. If I still feel there is something more to be done, then I go from the other side and cement it. Well, it can very well be done under local, but you can choose to do neurolab. Journal is out of question from my patients. It's surgeon's domain. What should be the OT like? Patient has to be fasting, part preparation, whatnot. But more importantly, all those things anesthetists know very well for that matter. Biplane fluoro is a very big help is there. But more importantly here is keep your OT at low temperature. It's overcool OT is very important because you cement to be overcool. Keep cement and radiopaque fluid and normal saline in the refrigerator. I even sometimes freeze dry these saline bottles, and those cement I do not be freeze dried, they have to be put in the butter area. Biplane fluoro is very good because you really save big time looking at both images AP later, like in cath lab. You can use that, they are available. I was in Hopkins, I saw these kind of things. But look at this, they have such a good tool with them. But what they were doing is when they're cementing the patient, they were not doing it right. because they're not using extension and traction. I'll tell you, I taught them, you do it this way, they appreciated it. I'll tell you again in my next few slides. Trolley is cool, normal line and other things. You'll see more trolleys coming up, some syringes, some needles, some stab knives, some LA needles. There's so many kind of vertebroplasty needles available these days. So you see what is right for the given patient. And there are so many kits also available these days. So you can choose to, but we are happy with our Jamshedi needles and even all those needles which are available, ready-made needles are available from different companies. I don't want to name those companies, but it's all so much of kit is available there. Then you have angle needles also lately. To kind of fill the specific area you want to, you can rotate these angle needles and fill them up at different areas. And there are something like, I must say it here, people who are good at it, they can put an endoscopy hook there, and you can elevate the end plate with the hook and can go ahead with the cementing thereafter, after elevating the end plates. Or you can use a balloon for that matter, for sure. But balloon is costly, hook is zero cost, because already they are with you. Yes, always keep extra needles, plier, hammer, everything there on table. So because you don't know when a needle may get choked and blocked, and I'll tell you how to change the needle after this. This is what I'm talking, the OT setup. Pain has to be an extension, because you want to decrease the anterior load on the spine, and I always give a traction here. There's a traction, you can't see it, traction here, because I want my spine to open up. I trying to create a cavitation in the vertebra which is osteoporotic, which needs a cementing, and then I go ahead and put your cement in there. And this is the position another time, by the way, and you can open up these fractures. Although many people would say they are not the one to be cemented, but I have done them in good number of patients. You have a height restoration with the traction and extension. So these all are routine things. I'm not going to go with them, but important thing is all measurements have to be done pre-operatively. Important here, this is most important. All measurements, all skin marking. It's like a war. Cementing is like a war. It is 5-10 minutes job. So you prepare for all this, and when you start putting cement in, then obviously as soon as I prepare my cement, so timer goes on. It's 10 minutes max mostly. And you localize, you find out the transpedicular everywhere is stab knife, K-wire. I use sometimes K-wire, and I'll tell you when and how. This is here you want to go in. Transpedicular, starting from here without breaching medial border pedicle. Another time I'll show you. Start from here, don't breach medial border pedicle, because your root is going next to the medial border. It's very obviously, I put this slide for same reason. Something like this. You're going transpedicular, this is the pedicle, and you look, your root is going next to the pedicle. So you want to avoid injuring to the root or cementing the root, and obviously the canal starts thereafter. This is what is there. People who are starting, who don't know much about it, they should know it. This is starting point. Never ever breach medial border pedicle until unless you have gone in. And if you are all the vertebral body, you don't have to look at the oblique view thereafter. It's an APL lateral, straightforward. After you've gone in there, it's so safe. And another important point is, try to be parallel to the pedicle. Don't breach the upper border, lower border of the pedicle. If you don't want to breach medial border, upper, lower borders also have to be secured. But there are instances where I don't bother pedicle. I'll tell you when, and I'll tell you after this. This is another depictive slide. Green is, you can go ahead, start from here. Yellow is, start getting more cautious when you're going into the middle of the vertebral pedicle and vertebral here in APN lateral. And red is the line which you don't want to cross. That's where until unless you're well gone in the vertebral body, thereafter you're not worried about this. And these are things put together very straightforward. Starting point upper outer quadrant. This is the AP view. This is the lateral view of it, and you can see this the axial view of it, where your starting point. And when you're going in further, you're in the middle of the pedicle here in the circle, pedicle circle there, pedicle oval you can call it, and that is where you are in the middle of the pedicle there. Once you're getting into the body, you're right close to medial border pedicle there, and you're already inside the body, and you're already inside body, you're not worried thereafter. You can go ahead, keep going in thereafter without any problem. Ravi, am I audible? Am I clear?
Yes, sir. 100%, sir.
I could see some here says, if somebody want to talk, somebody want to discuss, detail anything, you can talk to me. Because I can see here, I can see some kind of voice. So you can talk to the
request all the members to please mute your audio parts.
Because that will distract others, please.
Yeah.
Serious listeners should listen. Okay. This is so please mute yourself, my friends. Whosoever is admin can do that. Admin can do it. Right. So here is something where is the vertebra plana. So when I want to go into the vertebral plana, I don't bother about the pedicle. I just see the vertebral part of it, that I don't breach upper and lower border of the pedicle or the body and go in there, and that is how I just cement in there. So many times when I have to do this, I used to do it. Now I just all this latest technology is there. Navigation is good. These new tools have come in. They're very very useful and it can be made use of. But we are not the ones. It is the surgeon part. They do it. I was talking about the unipedicular. This was my first cementing. I'm talking long back. It's 2004. There's a history for that. I'll explain you later on if I get more time. And this is when you have to do a bipedicular. This is how we do bipedicular approach. For a bipedicular, I say we can go more straight there. We go from both pedicle. If I want to use unipedicle, I go more oblique, but I keep a watch on this medial border pedicle. This is not to be breached. And if I do a good job with single needle, look at this transpedicular, going right in the middle pedicle, right in the middle of this collapsed vertebral body. I turn my bevel to need to my requirement and just walk across. Remember, I'm not supposed to cross the lateral pedicular border because my vertebral body ends much before. So that is to be taken care of. This is the dorsal vertebra. The costovertebral junction has to be looked at. It should ideally be bipedicular or both sides instead of unipedicular. I do sometimes lower vertebral bodies. If I have to balloon up, I can start a little more oblique and can cross without breaching this and can well be taken care of. There I use a very special technique. I put in a K-wire first, and through the K-wire I just, once I am rightly placed with the K-wire, thereafter I just put my needle over the K-wire. So I do it, in these patients, needle over the K-wire, and just a few slides I'll just show you after this. Like, look at this, my needle over the K-wire. There is a reason for that. I'll explain you in difficult. Like this is D5, D6 or D fracture there. So when I'm putting these needles, if I'm not in a right place for the needle, so you don't have a big size of the pedicle and you're breaching through the head of the rib, you don't want to make big fractures there. So you want to put in a K-wire first, be satisfied with the K-wire and put a needle over the K-wire. So I used to do it very often, but keeping one thing in very clear, that there are big structures, the vessels and viscera, so one has to be careful you are not going to breach the anterior border. That's your vessel and viscera could be there. And this is when you do a cementing, look at this global fill. Excuse me. I presented this in traumatic fracture in 2005 in Sydney World Congress. And initially it was for the traumatic fractures I did 4 cases I presented in the Congress, and there was none done. Thereafter Chinese people came up with the more fractures. Excuse me. So my friends, now when you have more levels coming up, you have multiple levels to be cemented. Remember, there are times, so you don't go from one side because your needle will fight over each other. You go from a cross side, and that is how you go in and you just do your cementing, because your needle won't fight thereafter and cementing becomes easy. But you have more than one level. Always remember, you always aspirate the marrow. The reason why people are not doing more than one at a time was that he used to have a marrow which gets into central circulation and causes embolization. They call it marrow embolization, which can really hamper in some patients who are compromised by respiratory disease. And this is all about this vascular anatomy. When you go to cement these patients, your needle may be here, your cement may show up here. You're not to be worried. So this anatomy is very important, because some people do intraosseous venography. Now whether it is to be done or not to be done is your personal choice. Some people do it, now don't do it. It all depends, But if you do a venography and your cement goes all over, the dye goes all over the places like this, and you've known your vessel supply, and now you want to cement. Obviously you have to cement at the end of it. Now you start cementing, your bone is all dark and black. Where to put a cement in now? You can't see your cement drop of it. There is a problem. So there's a solution to that. If I do any time or my balloon burst, like in Kyphoplasty, someday balloon burst, the bone becomes all black with the burst balloon. You wash it with this saline. You have a normal line and sterile line. Wash with this line, make it clear again, and then you start cementing these patients. But always remember, too overzealous pushing of the cement or too fast pushing of cement can take it to central circulation. There has been a death. This is the going a cement needle in the heart here. So, and it goes into the lung many times. So one has to be careful. Well, another case like in tumors, if you're doing it, remember, if you're putting cement, tumor can migrate into the canal. So one has to secure the canal. I have a technique for that, I'll tell you. So those things have to be very cautious. You may be doing good job, but you don't know you're harming the patient than benefiting the patient. CT scans are good, in the cement viewing, but you are not doing in a CT scan. Some people do it, but here is a fluoro-guided thing, and you do in a fluoro-guided way. But it may come into the spinal canal. So those are not good things to happen. Very, very cautious. Well, I keep saying, there are 6 walls of a room. I don't want the cement coming into the posterior spinal canal. That's the only wall I'm worried. I'm not worried if it goes up, down, right, left, anteriorly. No, I'm not worried until it's too much of a problem. Only spinal canal is the one which is worrying me. And another point here is when cement chokes sometime in the needle, you have to change the needle. You can't push the cement in the same needle. You have more work to do. So what you do is you change the needle, bring the needle into the entry point here, make a zero view, take the needle out, and through this zero view, through the same track, you put your second needle in. I do it very often. So there are complications. It's going in inferior camera and the balloon getting burst, cement getting dislodged, or cord compression coming up, so many things, permeable embolism, and I told you about the heart patient also. So those are things. That's why it has to be done in a righteous way, in a right hand by the right person. But you all should learn it. It is doable procedure. Wonderful procedure. There may be cement here and there, but it's mostly inconsequential. Please understand, mostly inconsequential, but there may be few complications. It happens early in the career. And especially the people who are trying to do it alone and are very overconfident about the procedure. So there are issues. Or even if with me, if the day I'm complacent, I'm going to have some issue. So I don't want a complacent driving even if you are the Formula 1 racer. Radiopacity is most vital part of the procedure, because your cement, if it is looking very, very clear, each drop of it, then it won't cause any problem. And I have a technique for that, I'll tell you. Another important point is, there is a cement mechanics, and it is temperature dependent. So more cooler the cement, more liquid it stays outside in the ball, and inside body it becomes 37. So it hardens faster. This differential hardening is your help. But always remember, each cement has got different mechanism of a door time and working time. Please understand this part. Always see each cement how it is and what time you have at your hand. Work accordingly. Though 2 things which I said can be a very big help is making cement in the cold line. That's first thing. Very vital. When I'm mixing it, I try to see that my cement is ice cold there at this time, because its ice crystals are there. Second is, I put in after mixing the cement, I put in my radiopaque omnipaque dye to blacken out the cement. My cement gets all black on the view, and I'll tell you what, when I'm trying to put each drop of my cement, if you watch it very closely, I can see each speck of my cement, because I put in radiopaque dye, omnipaque, and you know how omnipaque looks on the shot, X-ray shot. And sometimes even I do a pedicle, cementing by intention in some patients. There are some cement which are phosphate cements. PMA may be very good looking, but again it has got its impact factor and other things there. That way the phosphate cements are better. They integrate well with the bone, and they are osteoconductive and bioabsorbable also. So this advantage is there with some extra cements, especially calcium phosphate cements are there, which are very, very helpful. And they have got a different mechanics. People who are students, they must take a picture of this slide, and what is the cement, PMA cement, composite cement, and calcium phosphate cement. And they got a different the properties to do with the biocompatibility, radiopacity, what is the curing temperature, means how hot it becomes. Cement gets very hot, and that's one of the mechanism of a pain relief. Toxicities, if any at all, what is the cost factor of it, and bioabsorption is there or not. So this all the different cement have got a different mechanism of that. Therefore people try to use CPC cement for vertebroplasty, because it has got extra advantage over the other cements that way. And then you have the combination of different calcium phosphate powders are there, and one should know more about detailing about it. And different companies have come in. and they are using different properties, different molecules, but they do all calcium phosphate work, and they are good by themselves with some changes. There is another development is people are using the chemotherapy agents, sometimes mixing with these things and putting in the vertebral body in the mat structure. It helps the tumor part of it. That can be done. Well, there are some kits which are very helpful, and people use it. If you don't have a money as a factor, if you're working with the richis, you're not worried. But in our poor setting of Indian people, you cannot use this costly kit, and that is the total cost of the operation many times. So one has to be calculative. How much is the kit cost, and cement cost, needle cost, procedure cost, hospital cost, and your surgeon cost. Otherwise, you come home empty hands. So those are there, say, but you don't want to compromise also. So that's what technique is there. So either you use those kits, or you have a help at hand is the 2 ml syringes, dual locks, and go with the very small syringes and very calculated things and get into the vertebral body. So mostly it is done in lateral position. Don't over inject. Under inject is better. Over inject, and there are volumes in the dorsal and lumbar levels. Use viscous cement as far as possible. Liquid cements flows, you understand. Viscous cements are harder and it gets harder faster. So one has to really calculate and stop cementing or injecting when you are the posterior 1/3. Well, with experience you will really know it's going to leak out any time, and you can stop it, and that's it. And this is how it goes. Start from anterior, keep going back, and at posterior 1/3, avoid it, leave it, because your anterior column is reinforced. That's what you want out of this. And this is, I just showed you this image. Well, there is some hindsight sometime. If you put a cement in block and you don't interdigitate with the bone, or put it places, you make it a cube or ball or anything, it may migrate out. So these things are known, please understand. So I always interdigitate the cement. But when you're interdigitating, always remember there's some very big mistake which does happen with me once in a year time, and especially in a very good vertebroplasty. You did a good vertebroplasty, you pull your needles out, and you don't remember your needle has a cement which starts looking and shining right here at the top, and you have a big cement needle hanging there looking at you through the parietes, and it becomes very difficult to remove this cement needle which is there, which is very painful and symptomatic. So the idea is, as soon as you have done with your work, you come out through the pedicle, you break the cement and needle cement, and this time you take the needles out after breaking the cement at the junction. There should be one line. The needle cement and the body cement should be in one line. You break it and come out thereafter. Now the practical scenarios of it. It's a quick fix phenomena. Put in a needle, cement. This is a patient had a fracture. Day 1, and same evening he comes to me. I put in a needle, put the cement in there. Next morning he walks back, and next week he is back to his work. Now I don't say next week, I say next day is back to work. As good as that. So the mechanism of pain relief, one should understand. What are the mechanism? Is by virtue of cementing fragments. That's very clear. You pull the fragments together, so there's no movement, like any fracture. You splint it and the pain is gone. And then you may be thermoneurolysis or vertebral end plates because of the heating of this. Washing away the nociceptor chemicals are there. Neurolytic action of the liquid monomer sometime is said to be the reason. And early ambulation and avoiding bed rest and osteoporotic and other activities, they get controlled there. So these are the reasons how the vertebroplasty and they help. I'm talking about 2006, by the way. This patient who had a polytrauma, and we were fixing their humerus bone, and we found she's got a back pain. Look at this MRI, the spine. She's got a burst fracture. 2006 again, and she's got burst fracture, and there's retropulsion also. So I cemented that time. Look at the beautiful holding of the vertebral body fracture. Look at the seahorse appearance with the retropulse fragment. Well caught with the cement. It won't move anymore, and patient is all fine. Sitting next day. Look at me again. So this is the next day of the patient. The patient is happy. Although she had few months to cope up with her humerus fracture, but the vertebral body fracture was an instant thing. So there is a vertical split fracture sometime. You can cement them. It is doable. And I show you a patient who was 919 kg when she came to me with the fracture, 2012. Cemented her. Look at this. I cemented her through and through. Look at this. And this is a different classification, burst fracture, vertical fractures. And this is She lost weight thereafter, about 40 kg. So they're back to life, they're immobile, they will start functioning. Another patient, live examples now. Patient was called me, Ravi. I was called in the ICU that this gentleman has got a fracture. I said, why he is in the ICU? They say he had a respiratory issue, big asthmatic reason. I'll tell you one very real story is that many of these patients who had a dorsal or the fractures, because of the acute pain because of the fracture, they get into severe bronchospasm or respiratory compromise, and they land in the respiratory ICUs. So this is something one has to understand. This could be the reason they may show with the painful fractures. Sometimes they don't complain the primary pain of the fracture. And he had a fluid come in here, so I put a needle layer, aspirated stock color fluid, put the cement in there, and patient is back to the life again. And by the way, he is diabetic blind. Over conservatism can be dangerous. Look at this, very good looking. Anybody will go for conservative treatment. But when you're treating this patient conservatively, never ever leave them alone. Look what happened in about 2.5 months' time. The 1 level fracture turned into 6 level dirty fracture. This is the original fracture. And the others have come up now, and they are much worse. Obviously, he was in pain, he was complaining. And thereafter, I did a 6 level cementing. One go, sagittal correction is already there. There's no leakage of cement in there, no leakage of cement across any place, and patient's absolutely fine. 3 levels I went from one side, finished with them, put another 3 needles, finish all 6 in one go, one sitting, 2010 I'm talking. So this is, I do always do a myelogram or epiduralogram to be very sure everything is all correct. And this is there, I got a little X-ray done, all fine except one epidural vein which is showing cement, which is okay. So their vertebroplasty outweighs conservative management in such patients. This is vital, this is important. Now, having an idea, this is the one which I was showing. I presented in the World Congress. This is Gabor Rax. And can you imagine, I got a compliment from Rax. I showed him this patient, and he said, Neeraj, I want to attend, I want to see your OT, shadow your OT to see how, beautifully you're doing all these things. So nice of him, gentleman, giving me that weightage. I'm talking 2012. It's been 12 years now. So this is what is balloon or kyphoplasty is all about. Put in needle, elevate the fracture, put in the cement, especially in the collapsed ones. And this is for height restoration or kyphotic angle correction. Look at the balloon. The idea, very fact is you can inflate this much balloon. That means this much bone is empty, straight. And you put a cement in there. Look at this cement taken up. This was empty, obviously. Patient had a fracture. Everybody knows about kyphoplasty kit, kyphoplasty set. The balloon is most important, and second is the inflation device. Rest all is just everybody knows the technical part of it. You can use single balloon, or I very often use single balloon, end plate to end plate, you can see it, or people use sometimes double balloon. It's a choice. Means I'm happy with single balloon. You see this? Means what better you can do it? Anterior reinforcement and end plate to end plate, right in the midline. That's what you look for. Another patient, right to left and right up from bottom top to bottom. Normally it is not all that required, but if bone is empty, obviously it happens. There are other expandable devices which is there. Meshplasty, this is the sky bone expanders, and the coils, and vesselplasty. There are so many things which is there. Lately there is a meshplasty device also there. So there are so many things, but attaining the same purpose, that you augment the height, fill the cavity part of it without any leakage. And this is meshplasty where cement lies inside, stays inside the mesh. That's the beauty of it, and it doesn't leak out. So, but then the cost is deterrent many times. I told you the kyphotic angle correction is what we are trying to achieve right here. And technically speaking, you make a space for the balloon first, put the balloon in there, hold the balloon in place, and while you're inflating, it does happen, I tell you, in number of times, the cement tries to go to the place of least resistance, it goes away anteriorly, laterally and all. You want to keep it at the place where you want to inflate. Please, this is important. Otherwise, look at this balloon. It's make a space here. Every time it will try to go to the same place. So you have to do another work. You have to hold it and make a space here thereafter. Look at this. So this is important, vital. Another such patient. I am inflating balloon, inflating in those two places. It won't go anywhere else. So you have to, by intention, take another place, well cement in there. So this is one of the recent patients. One thing I told you, if the balloon bursts, take the balloon out, wash the body and go ahead with the cementing part. About another very technical part of it. When trying to inject cement, make your cement should be flowy, especially in kyphoplasty, because you already made a space. You don't have to make a space with the cement. You have to fill the space with the cement now. So you don't be flowy like this. It should be a little hard and it should be going straight up in the sky. And then this is the time you just fill in the vertebral body and use a plunger in there and fill in the vertebral body right there thereafter. And this is it. This is, you make a void first, fracture void, fill it now. Fill it and forget it, I say it often. And many times the cord may be in danger because the fracture like this, I can't tell you the story of this tethered cord there because somebody did a wrong job, wrong surgery. Look at this, and I had to do a cementing of this. This is dirty fracture, by the way, for any no eye person. And other fractures which can be putting a pressure on the cord, putting a cement here is very, very no for many people, but I do it. I'll tell you how. Or in metastatic fractures like this, so I do it. What I do is I put a balloon in there. Before I inflate the balloon, I put a epidural and epidural balloon, splinting the posterior vertebral cortex and saving the cord at the back of it, and inflate these two things alternatively or together. And my bone is elevated. The spinal canal, epidural canal is seen. This is because of dye. You can see what is happening in my spinal canal. So look at this two beautiful picture. The end-to-end elevation, whole vertebral body augmentation with the epidural safety there, because these fragments tend to go back when you're trying to make a space in here. If this was not there, the vertebral bone would have come in here. So that saves my epidural space, and I have a fracture void coming in there. Fill the void in there, balloon up in there, still there. Take the balloon out, do a myelogram, epidurogram, and it's beautifully. I have a good night's sleep. Patient has a good night's sleep forever. No problem. Good night's sleep forever is every night, not forever. And this is, I presented in the World Congress in Jeju Island 16, and the talk was epidural balloon neuroplasty and foraminoplasty and innovation. So I did that, and this is how you do it in some patients like this. 2-level fractures, one balloon is good enough for 2 levels. Put the balloon in there, look at the cement void which is there, which I made with the balloon, fill them with the cement. Patient is happy, I'm happy. And by the way, many times in the older age people who are loner society now, nobody to take care, they are the only ones living with each other. If one of them goes, the other is already gone. So that way it is very, very valuable for them to be all hale and hearty. And we are all getting into that age now. So one has to understand this is important to be healthy by self. There are some potential complications of vertebral augmentation, but mostly they are minor, rarely permanent. But one should be very, 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 very conscious of those. And that's where you can avoid the accidents. If you drive every day, again, you should be very conscious of the facts. Then becomes a reflex phenomena. Well, there are some persistent pain after stabilization. It is maybe for a few weeks, it may happen because of needle and all, needle anesthesia, but they can be facet syndrome, SI, mechanical changes, costovertebral point tenderness, or you've gone to the dorsal vertebra and you can cause a fracture rib, head, and then you have unrecognized pathology which could be there. I told you the source hematoma or other things. Re-image, do another thing. Pedicle fractures could have been there, or you could have caused pedicle fractures, or maybe a new fracture. So those things have to be looked at. Sometimes there is a recurrence of pain. You've done a good job and it happens. Re-image and find a new fracture which may happen. I told you it happens. I have a lady 10 times with new fractures every time. And after first fracture, the chance of another fracture is high. I told you 66% adjacent level, 33% maybe distant level, or 66% in the first month and 33% in first year. There may be new fractures. Just very few beautiful cases for my masters sitting in the audience, like a patient who has done a fixation for this fracture was still in pain. Imagine 6 level screws are there and still in pain. I put my needle in there, balloon up there, cement in there, and look at the comparison. This is what the surgeon did and this is what my needle did. The whole thing, and this should have been good enough if I was a doctor for this patient. I never had to do all this. So this is avoidable. Look how I put my like putting needle and balloon through for this mid vertebral dorsal vertebra or there is not that easy, because you have to avoid lung, you have to go transpedicular, avoid the ribs and get into this, and these rods are there, they're coming in the way, and inflating it, putting cement in there is logical. But remember, this needle is there for paravertebral block. If patient had any problem, I can do a paravertebral block also. and the very patient walking next day in the morning before discharge. Well, there are patients with the failed kyphoplasties. Somebody did a kyphoplasty here. Imagine what is this cement doing here? It is not helping patient. Maybe some anterior reinforcement is there. Patient was in big pain. Look at this all broken thing. So this is called a cosmetic kyphoplasty. I don't like it. And this is what I had to do it, a redo. This was initial cement, this is my cement. Initial cement, this is my cement. And the patient is fine. So that is to be, we have to correct our, French mistake sometime. And this is 6th level. I did recently the cementing. I showed you 6th level 2010. That was osteoporotic ones. And this is metastatic ones. 6th level multiple myeloma. I cemented all 6th level. I had put in my group also, warrior group also. And this is, you can see 3 needles in one go and 3 balloons in one place. And this is what? This just as soon as patient is straight on the table, patient was saying, I am feeling I have to pass urine. I said, fine, wait for 5 minutes. And as soon as he was straight, he could pass urine. So first is the 2 things here. He was not incontinent because he didn't pass urine on the table. He was continent. And as soon as he was straight, he could pass comfortably. So that is another proof that everything is fine. This is very important thing. The patient is happy, I am happy. Another patient, a few years back, look at this. Can you imagine somebody putting a cement there? No, this is there. So you cannot, and this all vertebral plana you can call it. The 2 kissing disc I call it, and 2 kissing disc, no bone in here, and the cord is already almost getting tethered there. So put my needle in there, balloon up, open up the vertebra, put cement in there, and look at this. The anterior view of it, I have put a lot of cement in there. And look at this, the lateral view of it. I did a sagittal correction. Look at the angulation. I did a sagittal correction and put an anterior load-bearing vertebra. So it's a vertebral reconstruction, not just augmentation, reconstruction in other words. Just last few slides. I think we have over board now, but I still try to finish it. The few more slides were very interesting here. So this is the patient who was for the endoscopic work. He was waiting for the clearance and all, and he developed a new pain which was a fracture pain. And I did a endoscopic work and I did a cementing work in here. Immediately post procedure, half an hour, 1 hour, I just go and say hello to the patient, smiling. Look at the face of the patient. You want them to be happy. And this is another patient who had an ilial fracture. Look at this, the ilial acetabular ischial fracture. Look at this. He can't sit. He cannot stand at all, obviously. There's no load bearing structure. So I'm going in here. I'm putting my balloon in the acetabulum, going through the track of the taking bone marrow aspirate, going in there and inflating making some space here for putting the cement in there. I have a load bearing cement coming up. And this is it. Some more such like patients, ilial cementoplasty, another such patient. This is another patient, not the same patient. There was a cavity, big cavity in the ilium. And this is about the sacral fractures. And understand where the sacral fracture lies, mostly through this eye, or weak points here. So this is where mostly it fractures, insufficiency fractures or osteofractures or traumatic fractures. And you can go put your needle in there. What I do is, I put my needle in the operative room, take the patient to the CT room, and in the CT room do my cementing, because you don't want your cement getting onto the roots here. I used to do in my fluoro suite only, but there used to be a little risk about the roots getting, loaded with the cement. If you are very sure, you can go ahead in the OT itself, or you have O-arm with you. Otherwise, CT room is a good option. This is about the cervical vertebra. I used to do it. The same gentleman is a doctor. I did his D5, D6 cementing, I showed you. And he had a painful the cervical vertebra also, which was getting insufficient fracture. I put a 2E needle, metal 2E needle, some cement in there, and he was all pain free. Another patient, he had a C2 fracture. So I did a transoral, long back, 10 years maybe around, transoral getting into the C2, transoral in the tonsillar retraction there, and put my needle in there and did a few drops of cement, which is good enough for him. And this is the patient sitting in my post procedure in my one of my OPD settings. The commonest mats, by the way, just few slides for the metastatic fractures, are in the spine. Everybody knows, because there's so many vertebra there and it's a bony thing. And we keep getting day in, day out. Always do a bone scan, always do a colored MRI, CTs and everything. And if it is like in lung malignancy. So what I do is, in such situation, in this patient, I always try to take the pain away first. So I have a beautiful procedure which is intrathecal neurolysis. Very good procedure if you do it right. Any unilateral, You can take the torso pain, I write from D2 to D12 anytime I'll do it, this procedure. It's a 100% pain relief, and that is how, but this is very technical, know it, but it's a very doable procedure. So another patient who had a C3 fracture, look at this, D3, D1, D2, D3 fracture, the dorsal third vertebra, thoracic third, and I put in a cement there long back. It's again 2008, by the way. Look at this date, 2008, long back. And this is sometime lately I do is, I used to put in a RF needle first, but lately I've devised a technique. I'll show you that quickly. RF and RT together gives the best result in bone metastasis, period. This is discovered, this is known, is used also. Another thing which is common is, like we do a vestibular nerve ablation. So what you do is, same thing you're doing in the vertebral body fractures. If they're painful and metastatic, you can go in there and do a vestibular nerve ablation there, simple. And I show you the slides here. This is how you go inside, put a needle in there, and there is a vertebral body fracture which is there, which is painful. At least take the pain away. There's no supply there, so that is taken care. One such patient I just show you, putting my needle in there. Through the needles, I'm putting my, by the way, plasma. I have a plasma cautery for the endoscopic work. This is the most powerful, thermal ablation device. Very helpful. And people who know it, I am using Canon, by the way. Can you see, you can direct it to your need. You can direct it to your advantage. So I do a Canon ablation of the vestibular nerve and fill the cement in thereafter. The post procedure, patient is comfortable walking, must, and pain free. So all these procedures are there, which is helping patient from the pain point of view. Very good pain scores. The function point of view, quality of life is really improved in a much better way. So to conclude, that vertebroplasty is very safe and effective procedure, and it improves the mobility, quality of life, everything. So I won't leave any senile osteoporotic fracture alone to die in a misery, I'm telling you. And if there are more fractures, you can always handle, always treat them, and always treat the osteoporosis if you're doing first cementing even. And vertebroplasty should be the when the conservative management fails and you want to do it, or you're already doubting is going to be a sequelae because of the collapse, further collapse, or neurological involvement, or a quality of life going down, or kyphotic deformity coming up, I always like to go and cement these fractures. So vertebral augmentation, at the closing lines, is you can make it safer for wider application with improvisations. I'm doing for burst fractures, I'm doing for vertebra planars, I'm doing for burst fracture with the safety balloon in there, and I'm doing for multiple level fractures even in single sitting, and I'm doing for retropulse fractures also. Yes, everybody can do it, but safely and effectively, and definitely you have to have a technique in hand, and your skills are important. So there is a surgery phobia. Help these patients in MIS way. You should. Don't allow them to have a paraplegia and be on bed for life. I've seen many people in bed for lifetime because of vertebral body fractures and cord injuries. It's not unusual. And well, you're God sent, all of you. Remember, and you are skilled for that also. And try to do your bit, try to help the people, and have a countless blessings. By the way, God has graced you with that extra skill and knowledge and wisdom, and you all are there, and I want you all to help such patients who are in misery, who are in pain, and make them happy. From all the smileys, from sorrows to happy, and you can. The best way to define your future is to design it. We all are here to do best what we can. I know many of you are very learned people, but again I want to pass in a word that you be your best. That's the most important in life. You don't compare with anybody else. If you are your best, you don't have to worry. You don't have to worry about anything else, and that's your goal in life. And then you try to give best to the society as possible. And one best way of giving back is teaching. I say teaching is the best way of learning. So I'm happy that I could share my work, experiences with my friends. I do all these workshops and teach the people. I feel very satisfied. Many of you are doing great job there, and I'm getting blessing from those patients which you are helping and curing. So let's ignite more minds, let's teach more minds, and let's train more people. So we are having many hands now I don't work with 2 hands, I have thousands of hands now. So I understand, and that's what is a godly thing you can do. The Miami Declaration was that the pain relief is a human right. It's just a word. No, doesn't complete itself unless you deliver it. So it's as much our motto, as much our duty to deliver this pain relief, and we are not doing it for ourselves, my friends. We are doing for our generations to come, as a moral duty, medical duty, and human duty. Let's do it. Let's make this world better, and obviously that's the way only the things are going to get better, from worse to better. So let's do our best. Thank you, friends. Thank you for your time. Thank you, my friends, and thank you, Ravi, and thank you, IAPM body, and everybody, for allowing me to do this talk and share with you all, my friends. So it's my pleasure.
Thank you, sir. It was really a wonderful eye-opener lecture for all of us.
I know. I started from the basic. I went on to, because I had one talk to give. If I could split in two talks, one is very basic, which I could have expanded further, and one is advanced, because I would have add on more. But I had to concise the two together. That's why it's about an hour plus. I know some people are tired by now, but I'm bad at it, so I try to give what all I have with me.
No, sir, it wasn't at all bad. So I never took my eye off the screen, sir. It was a really wonderful lecture.
You're one of the rare, very learned person, and I respect you for that, your good work. So keep doing your great work. What are you doing?
Sir, just one question from the spectators. They are asking about the safety balloon you are placing in the posterior epidural space in order to avoid that retropulsion. What is it, and how you are inserting those balloons, sir?
So that's a trademark, by the way, number one. And I do it 1 or 2 level below transformally. This is a very trademark balloon which I have. So people can be one-to-one with me. So I put it up there against the posterior cortex of the concerned vertebra. I initially started doing it, frankly, for the PIVDs, to be truthful, initially long back, when I used to do Kyphoplasty and all. So started putting the balloons up and push the disc back into the place with the traction, and disc back into its cavity, and then I do Kyphoplasty, so that when the disc is shrinking, more space is created in the spinal canal, or the that way, for the cord structures and all. But thereafter I realized if I can place it against posterior cortex, long back again, 2012-13 I started doing it, and then I can have a more advantage out of this balloon. So many difficult fractures, burst fractures, retropulse fractures, canal compromise fractures, I could manage, I could do it, and it's doable. It's very much doable. I'm improvising it further, by the way, thereafter even.
Okay, sir. So that's a wonderful thing. I wasn't aware of these things, sir. So I was just going through the theories. Mostly the book says you have to avoid that retropulsion vertebra and everything.
I know, typically it has been written by all those ortho and spine people, and they don't talk about this technical thing. So I do my talks and lecture in World Congress of the, I told you about the minimalism spine surgery in South Korea, then again in the Bombay also, in other congresses. I go to New York and delivered my talk. Thereafter, I'm doing so many new novel things. I'm doing an intradiscal or transdiscal ultrasound also these days. Nobody has duplicated that yet in the world. So I'm having those slides with me. So I'm doing very new things, novel things. And I keep saying, Ravi, people like you and other very learned people around, do not stop what you get from the world. Go ahead, apply yourself, have your mind, marriages of concept, be innovative, and try to give back or give more what we have got. So what I'm trying to do in my way is I'm trying to give back more what I got from my seniors, with all due respect to my seniors, but I'm trying to do that add-on value. So it's just add value to that, and that's more important, because if we just keep repeating same thing what is given to us, we are not taking it any further. We have to go higher, we have to take it further on, and we have to add value to the science. And that's what I'm trying to do. And I'm stimulating you because I know you have that mindset. You have other people sitting in the group. I can't see them all. But yes, people, or even for that matter, other people whom I don't know. But still, everybody has got his own set of potentials. Please, so all of you, please understand, with your own set of potentials, keep maximizing. And I always say, no bounds. Except you should not harm a patient. That's the only bound which I say. Otherwise, don't draw your own boundaries. Keep challenging, I say. Keep challenging your boundaries, So that's what it is. That is how you keep going further.
That's the most important thing.
Challenge your limits.
So,
Don't limit your challenges. Challenge your limits,
Yeah, okay. So I think somebody's typing something in the chat box.
Yeah, they can ask me. Let me open the chat box. Yeah, just a minute. They can ask straightforward. You unmute them and then you can
Shrutika, you can directly ask.
Yes, sir. So this patient is 60. Sir, I've shared one MRI and X-ray of one patient. If you can see.
Yeah.
So this patient, she has this fracture. She had this fracture 4 years back. In L3 vertebral body with fluid and vacuum cleft at the superior end plate. So,
Just
but
a
there
minute.
is no
I'm trying to have a look at the.
retrogression.
1 second. Give me a sec. I want to see at
Yes,
this image again.
I
Chat box.
checked the MRI also and the X-ray as well.
Just a minute here. I just saw it. So I'm seeing first image and I saw the MRI also. 1 minute. Yeah, let me look at the MRI. Yeah. Oh yes, I see this. So you see, you in this picture, it's pretty clear. There's a fracture at 1, 2, 3, the third lowermost vertebra. So I'd never say L3. I say third lower. You don't know the counting part is maybe S1, it may be L5. The third lower vertebra which is there, which is fractured, and there is some retropulsion. There is a little of canal compromise, not too much, and there is adjacent level. This disease happens very, very often. You see it, the adjacent level, because of the change mechanics. The disc also starts getting misbehaving. In other words, that all tries to take importance. In other words, it happens. And there is a ligament hypertrophy at the lower level. Lowest one. There is ligament hypertrophy. So you see in the myelogram, there is a compromise in the myelogram. I can see. You can see those myelograms. There is impingement in the myelogram part of it. So know it. You have to treat now. I told you in one of the slide. I treat the disc also. I treat the vertebral fractures also. I do it very often, because you can't leave one and other things symptomatic. You treat one and leave other symptomatic. So I try to treat them all together. Possibly, yes, I can. If you can, fine. You can do it one stage. You can do 2 stage. If you can stage the procedure, you can do in one go. It's your call. Yes, you have a right thing to say. Well, nobody has cemented this fracture, the third last one, right? Is it that? So
Yes, nobody is cemented.
nobody cemented, because you have black thing there. Probably that I thought black thing is cement leak could have been there, but if it's not been cemented, it should ideally have been cemented. I told you about one vertebral body fracture. But if you see anterior column is okay, by the way, in such scenarios, I have to reinforce again. If anterior column is okay, you don't have to overdo it. You understand facts of it. Yes, you have few levels of disc here and there. The last disc needs little of treatment. You can't do too much. What's the age of the patient? What is the requirement? What's the age of the patient?
The 68-year female.
Only.
She has L3 she has pain along the L3 vertebra. Along with that, she has radicular pain L4, L5. So what we have planned is posterior decompression endoscopically L4, L5 and L3, 4 also. And
Yeah, I
along
think
with
that's
that,
okay. Doing endoscopic decompression alone is going to be okay. But if you don't do a angle correction, understand, there is a little of the kyphotic deformity, and there is a retropulse going on because of the angulation or sagittal imbalance. It's not instability, it's imbalance. So that way there will be a retropulsing of the fragment which will keep happening. But I think it's not too bad a case, not a very big fragment which is there, small fragment there, because it's a canal stenosis, which is lateral canal stenosis, is because of the small fragment, because of the ligament hypertrophy, and because of the collapsing of the disc there. So that's why on the myelogram is very clear evident that there is 2-3 levels of impingement on the level. And which leg is bothering, understand, right or left, because I see
Right.
myelo on the showing indentation on the right as well as the left side. So which leg is bothered, look at the level, find the level, treat it. You want to do a root block first, or you want to go ahead with the higher procedure, you can think of higher procedure. Endoscopy is on, but it's not great a procedure until unless you have a big disc fragment where you can correct it. I know. What do you want to do with endoscopy? What do you want to achieve?
Yes, sir. No, sir. I was just asking about the vertebroplasty part, sir. Like L3 for L3 vertebral, because superior plate is there and one vacuum is also there.
I know. It's not the vacuum part. It's just that there's a vertical split of the vertebra. I showed you one of the patient who had a vertical split, 119 kg. I cemented, and she lost weight at 83 kg, gone on to 83 kg. So that's what he had the back to life. but it all from different from patient to patient. These are little
L4
difficult
also,
fractures.
there is a little anterior wedging of the lower vertebra also, so that also needs to be cemented or what?
I know
Or
it's
just-
not the anterior wedging, is the anterior part of the lower end plate which is indenting, or you can S note kind of thing, So that's there on the one step low. So you can, if she is osteoporotic, get all those studies done. You can balloon up and open up this if you can lower end plate, but it all depends, how much is required. Don't overdo it. Or if you can't do kyphon by any chance, you can at least put in a cement to not let further collapse of this vertebra. Understand? This is still okay, but to not to let it further collapse, sometimes you just reinforce the same, even if the same is retained there. Otherwise, it tends to get like the one upper. The upper one is getting bad now. Now the problem is the vertical split. As soon as you put a cement in the vertical split, it tends to leak out. So there is a trick to that. Trick to this: go anterior most in that L3. Start putting cement in there. See how much you can put in the anterior part of this. There are two segments, anterior and posterior segment. If you look at two fragments of the L3, the anterior,
Yes,
and start coming back at the level where there is a kind of a dehiscence in mid vertebral dehiscence. You don't put too much of a cement. You put a little hard and little cement just for bulk formation and not to leak too much into the disc. I don't mind disc leakage for that matter, frankly speaking. And thereafter come back in the posterior fragment of that dehiscence fragment and put some cement in there, avoiding any leak into the epidural space, because canal is already getting little compromised. And don't allow cement to leak in the lateral spaces, because lateral spaces are further narrowed, lateral recesses further narrowed. So that is to be done. It is doable. A little technical case what you put forth is technical. One lower can be cemented. Many times you feel it looks good. You go inside, balloon up, it is empty bone. Or you go inside, put a needle there, start putting cement in, it is empty and it fills up nicely. Even if you put in a needle and put a cement in there, it is going to be reinforced at the lower one L4. And the upper one we are talking is you can fill it, and without any leakage posteriorly, I don't mind any amount of cement going in there in the disc or there or in the anterior segment or the posterior segment without any leakage in the canal. But yes, it's more technical. That's where I use all my balloon thing, which Ravi was talking, and that's very, very trademark of mine. I will splint my balloon against those three discal spaces, or these three, lower ones, the two discs, there, lower two discs, and the vertebral body. So if I put my balloon against L4 and L3, inflated 6 mm is the size of my balloon which inflates, or 6 centimeters the length. So I can just well fill the cement in there. I am not worried even if it leaks into the canal. I'll give you this theory. When I remove my balloon, 6 mm is going back to the cord is happy. So these are few technical things, but I cannot dictate it now at this place.
Sir,
Yes.
sorry to interrupt, but Shrutika, we won't be discussing in details. I have already taught most of the things regarding.
Yeah,
so,
yeah.
The case discussion, I will give you the sir's contact number. You
Yeah.
can
They can talk to me one to one. Exactly. But I thought for the group, if they want more, they are interested, they can discuss
Yes.
all this. Otherwise,
Thank you so much, sir.
Anybody have any question related to vertebroplasty or kyphoplasty?
True, for sure. There's so much which can be talked. Although I gave a lot of details and tips and tricks, but there's so much further which can be talked. Anybody can ask any question. More question you ask, more is the knowledge you take back home. So that's the advantage always. Interactive discussion is always welcome. Always you can have my number. You can talk one to one to me. So I appreciate that part of it. Anybody?
Can I share your number, sir?
Why not? Why not?
Okay,
I think probably last slide is already showing my number. If you just saw the last slide, and I showed it, and that is there. They can pick it from here.
Yes.
One more time.
Thank you, sir. I was having it. That's why I was asking for them only, sir.
No, you can put in the group. If you have a group, you can always put in the group. Right, Dr.
So I
Ravi?
think
Anybody,
somebody is asking
anytime, I'm there. I'm available.
Minimum how much volume of cement? So sir has already taught 2 to 3 and never you can be go under volume. but
No, the
never,
idea is never over fill the vertebra. Underfill is okay, but don't do too much of underfill, because the patient keep having collapsing fracture going on and they keep having more pain depending on what is osteoporotic cavitation. One should know. And if it's a dorsal level, cervical level, or lumbar level, depending upon the osteoporotic cavitation, it can take volume. The lumbar vertebra can take up to 7 to 8 or maybe 10 ml, and the dorsal and take 3 to 4 ml. Again, it all totally depends on the occiput cavitation, the fracture morphology. So always do a CT scan sometime, know the fracture morphology. And when I'm ballooning up, I'm opening the balloon, I know the balloon space, how much I inflated my balloon, that is the cement which goes in, depending on the balloon shape and balloon volume which I've put in there. So that much is cement, as simple as that. But if it's a plain one of those vertebroplasty, one has to restrict cement starting from anterior and say up to the posterior 1/3, and anything thereafter I have to be very, very cautious that when you're filling it, you have start putting a little harder cement this time in the posterior cortex and start giving a low pressure. Don't put a high pressure. Again, people want to make a mistake. When it's not going, they start putting high pressure, suddenly it jets into the spinal canal and a big volume goes in, 5 ml, 3 ml, 2 ml. And never use more than 2 ml syringe at any point of time, because even if you leak somewhere, it's going to be 1 ml or leak or so. If you have 5 ml syringe, you can leak 3 ml into the canal and there's an issue. So those are few things, how much is required. And I told you, I put a dye inside the cement, PMS cement or other cement for the matter. So I keep looking at each drop which is going in, and I very calculated, titrated, like you do in epidural, LORs and all other techniques. And you know, when you're going in, you're not doing one go, jerky go. So that's important. So cement leaks when your cement is getting harder and you're trying to over pressurize and you are under pressure. So the lead is keep 2 cements ready. Or if you have 2 vertebrae, if you want to go 2 sides, to make half cement at one time, keep 2 bowls ready. Everything should be in duplicate. 2 bowls, 2 spoons, 2 cements, or 1 cement, half and half. If I put 1 cement, I make half cement first. I use that cement and I now take them a second bowl. If my first cement is getting harder and I don't like that hardness of the cement, I take my second bowl and put the other half of cement which I left, make it, and then I start injecting the other needle or the other vertebra. So I do it very often. So if you don't mind keeping 2 cements ready, but if you can manage with 1 cement, 40 gram is there, you can make half and half, so it's no problem. So volume is absolute secondary. You should not be after volume, you should be after radiological filling. That's more important than the volume part. Volume is less important. How it looks on radiological fill is more vital, more important. Like in cervical, even half or 1 ml is more than enough. In odontoid, which are talking about C2, 0.25 would have been good enough, or half ml would have been good enough. So it all depends on where you're doing. And sometime in L4 or L5, even 5 ml is less. Sometimes you do from one side and you go from needle from other side, another 5 ml is going. So this all is there. So volume is secondary. Yes, it's important, but that shouldn't be a mainstay. Mainstay is radiological filling, how it looks after filling. Never ever overfill or over pressurize or over inject. And people say don't take it end plate to end plate, because there's impact factor. The chance of getting adjacent level fracture gets higher if you overfill it. With the PMA, with the phosphate you're not worried, but with the PMA there's a worry of overfill. So you don't want that to happen in your patients. So those are few things. But anytime leads are there, you can talk to me and share with me. Don't allow your cement to be filled in lieu of filling more cement in the body. Don't allow cement to leak into the canal. So I won't like 1 ml cement leak in the canal for a 5 ml filling in the body. I would be happy with 3 ml fill in the body without any leak in the canal. So that will be more important for everybody to understand. Yes, wonderful procedure, beautiful procedure. Please do it. I've done maybe 800-900 vertebroplasties and kyphoplasties together, and do it. I do lecture at different forums, and I like to share my experiences and views and doability. That's the first most thing, because many of these patients which I keep getting with the screws in places, and you don't like those patients getting screws in places. They could have been easily cemented. Just because they were not cemented by one of you and me, and they have got those screws in place, which is not a great idea. So I'm against that, until unless it is really required that you put a screws there. It's like a cardiac patient going to a interventional cardiologist or cardiac surgeon. Surgeon will say open bypass, go to interventional radiologist. They say stenting is a good idea, doable. If it's stentable with the result, that's always the best idea. So my idea is very clear. Try to give to the people, let more people know about it. There are going to be more and more people falling in line and falling in place and getting the right job done in good hands. So that should be your motive.
So we are getting lots of appreciation messages, sir.
Come on.
Thanks to you. Hats off to you.
And
I can see the Grey's Anatomy, the previous edition book. So how?
I know. I've got so many of them. If I just take it around, this all is a small library, half the library,
Yes.
And there's another
Thanks
clinic
a lot,
which
sir.
has got
I think so.
another set.
Yeah, sir. Please. Yeah, please.
There's another clinic of mine which got another set of books, So I am very bookaholic, I keep reading and keep going through. I love to.
Okay, that's a great thing, sir. So I think we can conclude, sir. This
My
session.
pleasure. Absolute pleasure of mine. Anybody can be in
Yeah.
touch with me. So just because I had one chance, so I try to pull all things together. If another time we can get 2 bifurcated lectures would be better. But anyway, I'm very, very happy. People are still around. So many people are still around and listening through and through. That shows the interest. That shows their interest.
Yes.
Right.
Thank you, sir. Thanks a lot for joining us. And now we'll be concluding.
My pleasure.
So we'll meet again. Thank
Right,
you, sir.
right.
Once
Okay,
again.
bye-bye. Good night.
Bye, sir. Good night, sir.
Keep doing good. Thank you. Thank you, my friends. Take care. God bless you.